Hi, I'm Dr. Alex Kabiri, OD. I'm here at the AOA meeting 2024. Great meeting, great show. If you're not here, get here. If you're here, get right here, because here is where we're doing some really cool stuff. We're going to show you how to apply amniotic membrane to the front of the eye. One of the key things you want to have is, of course, the patient, right? No patient, no procedure. You want to have a patient. You want to make sure that you understand what you're treating and why. Usually we're treating some form of keratitis in the office. Much of the time, these patients will have some sort of dry eye as well, but keep in mind, you're not necessarily treating dry eye, you're treating some form or forms of keratitis that have either contributed to the onset of dry eye, its propagation, and at the least are interfering with its improvement. So when you have patients for whom you've identified they have dry eye, you're treating them with seemingly appropriate dry eye treatments, but they're not getting better the same way other patients are. That's when you start thinking about other forms of keratitis that are running on the front of the eye and how to put a quick blanket treatment over all of them, snuff them all out so that the patient can have the ocular surface optimized in record time. And then you're going to notice your dry eye treatments of choice work much better when a lot of this other stuff is out of the way. So we have a patient ready to go here. She's also going to assist, which is not really the norm, but we're doing it as a demonstration. One thing that'll save you some time and get the timing of the whole procedure right is having your stuff out and ready to go. So what we have out and ready to go, we have alcohol pads, we have our jeweler's forceps, we have a bandage lens, we have our membrane, and we have our proparacaine. We also have a drop of Maxitrol ointment, which I'll show you for demonstration purposes where that fits in at the end. But we do, Maxitrol drops, not ointment. We do oftentimes give a combination antibiotic steroid drop as part of the post-procedural regimen for that few days of treatment. Why? Because when you sleep with a contact lens, your most two common concerns are hypoxia and infection. The dexamethasone component will very safely and effectively keep that hypoxic sequelae at bay. Things like corneal infiltration, ulceration, anterior chamber reaction, corneal edema, all that stuff will be nicely at bay for a few days very safely with the dexamethasone component. The Maxitrol, in this case, you could use Tobradex as well, but the Maxitrol that I have here, neomycin, polymyxin B, those are going to keep most of the common ocular surface bacterial pathogens at bay as well, safely and effectively for the duration of treatment. So we've identified she has some form of keratitis, she's signed a consent, she knows what we're doing, she understands why, and is optimistic about getting a good outcome. So we're going to go ahead and give her tissue. We're going to give her one drop of proparacaine to each eye. We're treating one eye, but we're going to go ahead and put one drop in each eye. Why each eye? Because if she feels the need to blink one eye, well, the other eye is likely going to blink as well. And if that's a poorly timed blink for us performing a procedure, it could disrupt the procedure. So she'll look up to the ceiling. Good. There's one and two. She'll gently close for about 30 seconds. You can dry your eyes if you like, but don't open for about 30 seconds. Of course, if her eyes are closed, she's not blinking. If she's not blinking, the drops are staying there. Prolonged contact time with the corneal surface, enough time for the drops to take maximal effect. In the meantime, while her eyes are closed, we'll get ourselves ready the rest of the way, which is going to mean making sure that our forceps of choice, something with no teeth, it doesn't have to be an angled jeweler's, that's my personal preference. We want to make sure that's ready to go. We want to make sure our bandage lens is ready to go. Now, normally when we do this on a patient, we're putting a bandage lens on the eye. We're putting a membrane on the eye and then a bandage lens over the membrane, and that's kind of it. I don't want this to actually stick to her eye during a demonstration. So whether you're practicing with a partner, practicing with a student, or just practicing on somebody that you don't really want it to stick to their eye because you're just practicing, put a bandage lens on the eye first. Put a contact lens on the eye first to protect the eye from the membrane, then apply the membrane and then your bandage lens. So it's kind of like a sandwich, but we're doing that just for demonstration purposes. In reality, you wouldn't do it that way. There would be the membrane and then a bandage lens on top. All right, so to see the way it comes packaged, there's sort of an arrow here and here. You want to open the side that the arrow is pointing to. That's already ready to go. Open. If I open this too quickly, you can see our membrane right down here. We have a small 5mm disc here. If I open it too quickly, they're very light. There's a bit of a static charge to these sometimes as well, and the air can take it away and you lose your membrane. I've snatched them out of the air twice, but I don't want to make a habit of it. So I'm going to open it enough to get a hold of it. So I can now grab it with my forceps, but I'm not just tearing it open recklessly. I'm going to put the first lens on the eye again because this is a demonstration. We integrate with either what. So if we're doing her, let's say, left eye, she's going to just look straight ahead. Good. A little bit up if you can. That's fine. Don't blink, don't blink, don't blink. Good. Slow and easy, look straight. I'm going to let the lower lid go, let the upper lid go. Again, for demonstration, now she's protected from the membrane itself, right? Now I have what's going to perform as my bandage lens here. I'm going to do something that you might not see a lot of folks do, which is drain most of the fluid here. And I'm going to do that because I don't want to introduce so much fluid when I place this membrane that I destabilize a membrane that's trying to adhere onto the cornea. Good, good. Or you can just pour it out like that. One way or the other it'll work. All right. So I'm going to have, if I had, let's say, a staff member or assistant here, they'd be doing this part, but she's going to go ahead, Teresa's going to go ahead and hold the lens. She's also going to hold a rounded ophthalmic sponge here that we can use. I'm going to reach in here, grab the membrane, very, very small, not sure if you can see it, 5mm disc there. All right. So she's going to look towards my eye, right here towards my eye. I'm going to not let her blink. I'm going to place this neatly over the area of the defect, which for our purpose is going to be slightly superior of central, slightly superior to our visual axis. It'll slide around because I'm placing it on top of a contact lens, which is not what I would normally do. I'm going to take my rounded ophthalmic. I'm going to gently press and roll it into place a bit to make sure that I have 100% surface contact with the surface of the eye. Good. Great. And now, because I'm in front of her, just the ergonomics of using my thumb are going to be easiest. To put my bandage lens on, I'm sorry I'm blocking your view, guys, I apologize, but it's on. So now I'm going to let go of the bottom lid, gently let go of the top lid. She's going to kindly close her eyes. She can move her eyes left and right a couple of times to massage out any air bubble that might be trapped there, and eyes open. Now, if we were in the office, I'd tell her to keep her eyes closed for about a minute or so, during which time I'd spin around, finish my chart notes, send what I want to send to the pharmacy, which is likely going to be a non-preserved artificial tear. I'm going to suggest that she uses it every 3 to 4 hours while awake for the duration of treatment, and I'm going to probably send either Tobradex generic, Tobradex ST, or Maxitrol drops, 1 drop to the affected eye 2 to 3 times a day for the duration of treatment, which is usually somewhere between 2 to 7 days, somewhere in that range, depending on who and what we're treating. How was it for you?
Easy. Easy peasy. No pain, no nothing.
Well, no pain, no gain. So now, so if we took all the talking and stuff out of it and the explaining out of it, it's very, very quick. I mean, from the time that she, she gets the proparacaine drop, from the time she opens her eye to the time she closes her eye and procedure is done, maybe 30 seconds tops, maybe 20 seconds, something like that. Very, very quick. But when we add all this to it, it adds a minute or two to it. Good luck. Come by the booth. We're here all day today and tomorrow. So best of luck. See you soon. All right.